Good evening, everyone. We welcome you all to OrthoTV Online in association with Orthopaedic Research and Education Foundation, OREF, to introduce today's speaker and the topic. I hand over to Dr. Arvind Prasad Gupta.
Good evening, everyone. I welcome you all to our continuation of the CME, particularly for the post-graduation student. Today we have Dr. D.K.Taneja, sir. He is also a member secretary of this OREF Foundation, and he is medical director and senior consultant in Arihant Hospital and Research Center, and he is the founder director MGM Allied Health Sciences Institute. Sir, stage is yours.
Thank you. Am I audible to everyone?
Yes, sir. It's very clear. And
okay. Yeah, it's clear today.
Well, dear friends, on behalf of the Orthopaedic Research and Education Foundation India, which was the main child of our senior Professor Mukhopadhaya, and the main objective was to update our postgraduate students from time to time. And in this series, I must say, the John has taken lots of pain. And during the last few years, when we are not having any physical meeting, we are having lectures almost every week. And this time, we are going to talk about the surgical anatomy of the knee joint. As you all know that the knee joint is not a simple joint. It is a very complex joint. It needs lots of stability. At the same time, it requires a lot of motion. It has an important role to play when you are standing, work in full coordination with the hip joint and the ankle joint, when you're running, jogging, or playing any game. And knee joint is one of the most commonly injured joint in the body, whether it is a football, and many players have ruined their career because they injured their knee joint, whether it is a tennis, any game you take, that there is a lot of problem with the knee joint. So because knee joint takes all the load while you are in a very active sports, and or even in the routine time when you're walking or jumping, climbing the stairs, coming down the stairs. Therefore, it is important to understand how the stability of the joint is maintained. And as you all know, that the knee joint is basically, there are two important joints. One is the Tibio-femoral joint, as you know that, and between the lower femur and the upper tibia. And a very important joint, which is sometimes ignored, is a Patello-Femoral joint, which plays a very important role in the whole working of the joint kinematics. And we try to find it out what happens in the Patello-Femoral joint. We must try to, for our postgraduates, that after all, what is a biomechanics? You know, biomechanics is a science of the action of the forces. And since it is going to happen, what we are going to study in the human body, it is a biomechanics, okay? So you can have a static forces, or you can have a dynamic forces. Static forces, when the body is at rest. Even when the body is at rest, your quadriceps muscles are working. So it is causing some static forces onto your joint. And dynamic forces when you're running and you're jumping or doing whatever the activities, and whatever the muscles are functioning at that time, they are producing different types of forces onto your joint, and that may affect your motion of the joint. So the joint mechanics is important to understand about the degree of freedom the joint will enjoy, what will be the joint reaction forces, what will be the joint congruence, that's important, what will be the instant center of rotation in that joint, and the different friction and lubrication. Now, the two terms, kinematics and kinesiology. I'm talking to you about my postgraduate student. The kinematics is a study of a motion in terms of displacement, velocity, and acceleration. That is a science of kinematics. Kinesiology is the study of a human motion. So these are the few terminology. What is a biomechanics? What is a static? What is a dynamic? What is a kinematic? And what is a kinesiology? If you see this year's DNB question papers, I was rather disappointed to see those question papers, and some of the things which has been asked are usually not very liked by our students and teachers. Now we all know that the knee joint is one of the most important example of a very important hinge type of a synovial joint. Okay. Now the important motion that takes place at the three degrees. One is it is a flexion and extension. Okay, that is taking place. Then it is the adduction and abduction which takes place. Okay, and then the other important is the rotation that is taking place, which occurs in a transverse plane along the longitudinal axis. So this is a very important joint that in 3 degrees you can have a motion. The people only think that the most important motion that is taking place at the knee joint is the flexion extension. True, but there is an adduction and abduction and a rotation at the knee joint, although this is a limited movement. Okay, fine. So the extension is more or less hardly an extension, maybe about 10 degrees or so. But the flexion range is extremely good, which is about 130 to 150 degrees. And we'll show you that how this, the lower end of the femur forms a J-shaped curve. And the most important thing that is in the biomechanics of the knee joint is that it is just not flexion and extension. When there is a flexion and extension is taking place, there is 3 movements which are taking place. One is called as the rolling. You see, as the extension takes place, there is a rolling back of the femur. We'll show you. Or when there is also in the flexion extension, how the tibia, the femur will slide front or at the back. Okay. Even at the time of a full extension, there may be a rotation, about which we'll call as a screw home movements of the knee joint. So this is that it is not simple just flexion and extension. During this flexion extension, the rolling and the sliding motion all taken together, and at the terminal degrees, they are associated with some degree of rotation as well. So this is, you see this picture, which shows that how typically it is like a hockey stick. You can see this typically J-shaped type this thing, and which shows, indicates where will be our axis of rotation. So the rotation axis lies very close to the medial condyle. And at 90 degrees flexion, when you flex it, you can have almost quite a degree of external rotation and internal rotation at the knee joint. The adduction abduction is very limited. When it is in full extension, because all the ligaments tight and you have no adduction and abduction. And only when you have about 20 to 30 degrees of flexion that you will have some degree of adduction and abduction. That is where it is important, where you are doing the varus test or a valgus test that will give you an idea about the damage to the joint, whether it is a collateral ligament associated with the cruciate ligament, or it is simply a collateral ligament injury that can only be assessed when you're doing a proper varus or valgus test. The articular surface, if you see the femur, it is the lateral condyle and it is the medial condyle. And here is the intercondylar knot, and here is the sulcus where the patella will fit into this thing. And you can see that the articular cartilage is right up to here, and immediately this anterior portion is wide of this thing, but whole the posterior area is well covered with the articular cartilage. The femoral tibial condyle is the two lateral and the medial condyle. And you can see that there is a slope of 7 degrees. And this is what we use when we are trying to do a total knee replacement, that we want to have a cut about 7 degrees to achieve the anatomical position. And you know that between the two condyles is the intercondylar tubercles, and these tubercles, when you have a full extension, they come to lie between the intercondylar notch. So, and these two are comparatively flat as compared to the femoral components, which are much convex, and they fit into the two condyles of tibia and femur. Now we are talking about the two axes. You know that there is an anatomical axis and a mechanical axis. Now it is important because you see when you're trying to do a joint replacement, you want to have a proper mechanical axis, achieve this thing. Our goal is to this thing. And we also know that between the two axes of femur and tibia, that this is in an angle of about 180 to 185 degrees. Now, if there is an alteration in this angle, then what will happen? If this angle increases, there will be a knock knee, okay, there will be genu-valgus. If this angle decreases, it will be a genu-veno deformity. So this achieving these angles when you are trying to do any surgery is of paramount importance. We should also understand a few things, that a tibial articular surface is about in 3 degrees of varus, femoral articular surface in 9 degrees of valgus, mechanical axis is in 3 degrees of valgus from vertical axis, and anterior axis in the femur is 6 degrees valgus from the mechanical axis, and anterior anatomical axis in tibia is 2 to 3 degrees of the varus from the mechanical axis. So this is important to understand the little bit of variation when, especially when you are trying to do any surgery on the knee joint, and especially those who are doing a total knee replacement. The very two important things in the joint is a menisci, and the menisci are very, 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 very important. And there's a lot of work has been done on the menisci. Do you know that they are the two fibrocartilaginous structures? The lateral one is more circular, medial one is a C-shaped. Lateral is much more mobile compared to the medial one, and therefore the medial one is torn more often. And there is semimembranosus, which is attached to the medial meniscus. Now the anterior horns are attached by the intermeniscal hinge to the tibia, and the anterior horn of the lateral meniscus and the posterior horn, both the menisci are attached to the intercondylar eminence. We all know that, and the popliteus is attached posteriorly to the lateral meniscus. Now, if you see this diagram very carefully, you will find that the lateral meniscus, you can see that is almost circular, okay? And if you see that medial meniscus, it is almost a C-shaped. This is much more mobile comparative to the medial meniscus. And you can see that how intimately it gets intermingled here with the fibers of attached to the tibia upper condyle, and here it is the posterior cruciate ligament and the anterior cruciate ligament. Now these menisci are very important. Somebody may ask, my PGs may ask, what is the role of this menisci? Menisci play a very important role. 1, they provide stability. 2, they act as a shock absorber. 3, they increase the congruity between the femur and tibia. It prevents synovial impingement, therefore you may not have pain. It limits the extreme movements of flexion and extension. And most important is that they share 50% of the load between femur and tibia. That's very important. And therefore, it causes the contact stresses, and it also is responsible for some degree of lubrication of the joint. Now, when there is a compression between the femur and the tibia, the menisci tends to move outward. However, it is the circumferential tension inside the menisci which counteract this radial force, and menisci remain in their position in spite of the fact there is too much of compression forces are created while you are playing any fast game. Let us have a look that if you have a joint where there is no menisci and where you have the menisci. Now, if there is no menisci or meniscectomy has been done, so what happens? This whole femur on the tibia, it sits on a block here, and then the stresses are very high because of very limited contact. You can see that, okay? And therefore, the damage to the articular cartilage will be very fast. And if you had a meniscectomy done, you will get a very early osteoarthritis. Now, whereas if you have the meniscus already there, then with addition of the menisci between both blocks, that is the contact area, it increases and the stresses are decreased. And thereby, there is a less of stress on the articular cartilage, and therefore the damage to the articular cartilage is not as early as it will happen on this side. Therefore, now nobody is doing a full meniscectomy. We are just doing the balancing, whatever the part of the meniscus has been this. And even the people are now doing the repair, those who are doing arthroscopic work too much, they are doing the repair of the torn meniscus because the meniscus has been found to be of extreme importance. I remember in my own case, I was a footballer and I broke my knee joint way back in 1961. And I had a bucket handle tear and a full meniscectomy was done. As a result of that, I had developed a severe osteoarthritis right from when I was the age of 50 years. However, my right knee is perfectly well and I managed to continue and by yoga and whatever it may be. So this is important. So the meniscectomy, when there's a partial meniscectomy, in the contact area, the stress increases by 65%. But if you have done the total meniscectomy, you can imagine the biomechanics studies say that the stress in the contact area increases by 235%. Now, we all know that the joint is covered with a capsule and a synovial membrane. Now, you know, when the synovial membrane is being developed, part of the synovial membrane gets absorbed and whatever the essential synovial membrane, it remains in the joint. However, at many places, this synovial membrane folds don't get absorbed, okay? So at many places like on the middle side or in the inferior side or somewhere in the superior side, and these folds of synovial membrane are called as the patellar plica. And these plicas sometimes undergo inflammation, and because of the inflammation, there is a pain in the joint, and then of course, this is also called as the plica syndrome, and our arthroscopic surgeons will go in and tackle these problems. So these are the folds which remains unabsorbed during the growth and the development of the joint, which are called as a plica. The joint also has important ligaments, the medial collateral ligament, the lateral collateral ligament, the oblique popliteal ligament, the posterior oblique popliteal ligament, arcuate ligaments, and medial and the lateral branches of the ligament. Out of these things, the most important two ligaments on either side of the joints are medial and the lateral. What are their functions? Mainly is to prevent any varus or valgus strain and also help in stabilizing the tibia so that it doesn't get translated anteriorly and cause any instability, and even also prevent any rotation of these tibias, and it helps them that how the knee joint can be stabilized. So these two ligaments are very, very important. And very often they get torn in the active sports, and you have to be carefully be repairing them and diagnosing them. The most important ligament is an anterior cruciate ligament. The books has been written only on anterior cruciate ligament, and you know that it is a intra-articular but extra-synovial. It has anteromedial fibers. It has two group of fibers, anteromedial fibers and posterolateral fibers, and they're intertwined with each other. And the anteromedial fibers are tight in flexion, and they limit the anterior translation of the tibia forward. And posterolateral fibers are tight in extension, and they also limit the anterior translation plus the external rotation of the tibia. It has also an important proprioceptive role, and you need a heavy force before the anterior cruciate ligament gets torn. It is one of the very strong ligament and very important stabilizer of the joint, and therefore the most of the players to get into the problem is because of the anterior cruciate ligament injury. But because of these days a high-tech technology available and very good reconstruction of ACL has been possible, and patient can go back to active sports. So the ACL is a very, very important this thing. The muscles have a very important role to play. Now, if you find that anteriorly there is a group of very strong group of muscles, and that is the quadriceps group of muscles. When the quadriceps group of muscles are trying to contract forcefully, obviously they're trying to create a force here, and because the patellar tendon is here, the quadriceps is coming this way, and they try to bring the tibia anteriorly. However, posteriorly, there is another important muscle, and which is the soleus muscle. When it contracts, it counteracts the forces generated by the quadriceps group of muscles, and these remain stable. This is a very important. Another way, the counter to this thing is another very important ligament, and that is the posterior cruciate ligament. Now, the posterior cruciate ligament has got the posterior medial fiber and anterolateral fiber, and this it limits the hyperextension and prevents the most important in the posterior translation of a tibia. So, whereas the anterior cruciate ligament is important of preventing the anterior translation, the posterior translation of tibia is prevented by the posterior cruciate ligaments. So these are two, both of them are very important, because one of the most important thing, if any of these cruciate ligaments are torn, is that the knee is giving way. That means knee is unstable, and any unstable knee needs to be looked into. A very important structure in the body is a ilio-tibial band. The ilio-tibial band, as you know, is formed by the fibers of the tensor lata and some fibers from gluteus maximus and gluteus medius, and this band is formed. It's a very important band lying on the lateral side of the knee joint. It supports the knee joint, and in flexion, the IT band tends to migrate posteriorly, thereby it increasing its ability to restrict the excessive anterior translation of the tibia. Now, if you look into the active sports, most of the games, that when the patient is playing either hockey or is playing football or is playing tennis, when there is a sudden he is running and is trying to stop there, there's a tendency for the tibia to get anteriorly translated, and the whole force is come under the anterior cruciate ligament. In order to help anterior cruciate ligament to perform its duty well, the nature has provided these structures like ITB, the posterior cruciate ligament. All these things tend to provide and add stability to the function of the anterior cruciate ligament, and thereby keeping the knee stable at the time of a very active sports. We have already talked about that the tibio-femoral joint is just not flexion and extension. It is the rolling of this thing, and also it is a combined rolling and slide. Now, this usually things we find that the movement is taking place in just one axis. is not so. And this is how this important thing we must try to appreciate. And with the different structures, these complex movements go simultaneously and one doesn't realize what exactly is happening. Now, when you are a weight bearing, then what is happening? Tibia is fixed and it is the femur which is moving. Now, during the flexion, the femur rose posteriorly, okay, it rose posteriorly. Femur glides anteriorly, and the remaining movement is rolling during extension. Femur rose anteriorly. Femur glides then posteriorly. So this whole movement of glide and rolling almost goes together. One cannot appreciate it unless you make a very slow motion this thing. In a non-weight bearing time, it is the femur which is fixed, and tibia is moving during flexion, and tibia rose and glides posterior. So tibia has also, the question is whether I am standing or I am sitting, I am walking, I am running, what is happening. So this gliding and rolling movement goes together. Now, what happens to the cruciate ligaments in flexion and extension? Now, these, if we are trying to do the flexion, then what happens is that the anterior cruciate ligament gets very taut and it has a tendency for it to get translated anteriorly. On the contrary, if we are trying to get in an extension from a flexion position to extension, then it is the posterior cruciate ligament which tries to get taut and tries to get the whole tibia translated posteriorly. But because of the anterior cruciate ligament, the posterior cruciate ligament, and the other structures like menisci and other structures, they all help each other maintaining the position of the tibio-femoral articulation in anatomical position, and thereby allowing any gliding and rolling movement simultaneously, and also keeping the joint absolutely stable is the duty of these two important cruciate ligaments. The rotation takes place in the rotation. The most important part is played by the tibia. Okay, so in tibia, it is mostly the lateral condyle which moves, like you have when you're trying to test an anterolateral instability, then you try to rotate it, the tibia medially, and you will find the whole tibia is subluxating forward. So it is mostly the lateral condyle which moves, which has got a much better contact area. And whereas in the case of the internal rotation and external rotation, you can see the contact area between tibia and the femur. There's an important movement which we try to understand, and that is the screw home mechanism. What is a screw home mechanism? It is basically creating a stability at the joint when you are standing. So this is what we call as a locking mechanism. So when you have in last 10 to 20 degrees of extension, as you're trying to do extension, the tibia starts rotating externally and femur starts rotating internally. And when you have reached to a 0 degree, the knee is supposed to have been locked and it is a most stable position. This is called as a screw home mechanism. Now let us see that. The knee is going into flex position, and this is how when the knee is trying to go into a extension, that the rotation takes place and the knee gets totally locked. And if it has to be unlocked when you are trying to do the flexion, it is the popliteus which comes into force, and it causes the opposite movement, and thereby you get the knee unlocked and the flexion movement starts. So this is a very complex phenomena which looks so simple when we are talking about. Just think of that what is happening when you are running and you are doing any motion at the knee joint. It's a very complex phenomena. Now the important thing that we try to understand is that in the what cordyceps plays an important role. You see the quadriceps muscle, when the quadriceps have a forceful contraction here and the patellar this thing here, and knee is in trying to go into extension, with a forceful contraction of the quadriceps, the tibia tends to translate anteriorly. Okay, that's a very important thing. Again, the cruciate ligaments come into action and they prevent this thing. However, when there is a knee is in flexion, then the force of the quadriceps is not that much, and the tendency for the tibia to go into anterior translation are not that much. So the quadriceps has an important role to play, especially when from flexion you are going into into extension, and thereby the chances of getting an anterior translation are very important. So this is what happens. Then when you are playing a game of football and you find the ball is coming in front of you, and you suddenly from a flexion position and you lift your knee and try to kick that ball from flexion, you go to the extension, and that is the time when there is a lot of force generated over the anterior cruciate ligament, and the injury to the anterior cruciate ligament can take place, and thereby the instability in the joint can come up. So I'll just give you this chart, which is a very good chart for you, for my postgraduates to remember. You know that there are anteromedial, anterolateral stabilities, posterolateral, and posterolateral stability. Now, in anteromedial stability, anteriorly you have the medial collateral ligament, the posterior oblique ligament, the posteromedial capsule, and anterior cruciate. They are important for maintaining the anteromedial stability. However, for anterolateral stability, wherever there is the anterior cruciate ligament has to play its very important role. But you can also have, because it is the lateral side stability, lateral collateral ligament will have an important role. Posterior lateral capsule will also have an important role to play. Then the arcuate complex, popliteal, and the ilio-tibial band, which are on the lateral side, will have important role to maintain the anterolateral stability. The posterior stability, of course, on both the sides of the posteromedial or posterolateral stability, it is the posterior cruciate ligament which is important, and then on the medial side, it is the posterior oblique ligament, where on the lateral side you have got arcuate complex and the popliteus muscle. And medial collateral ligament, the lateral collateral ligament, here the semimembranous tendon, and here, of course, the biceps femoris tendon. So this is how the posterolateral capsule, and here the posterolateral capsule. So this is how the stability, the rotatory stability at the joint is maintained by these structures. What, again, trying to understand, if it's anterior stability, it is the cruciate, anterior cruciate which plays an important role, and the medial collateral ligament. It's a late anterolateral, again anterior cruciate ligament, and lateral collateral ligament and structure on the lateral side like biceps. If it's a posterior stability, it is the posterior cruciate ligament on both the sides, medial and the lateral, and also there will be the posteromedial capsule, the posterolateral capsule, on the middle side the hamstring, on the lateral side the biceps femoris. They play an important role. So any of the structure which gets torn during the injury, they can lead to the instability, and that part must be taken care of and it must be repaired. Now we talked a little bit about the Patello-Femoral joint, which is very important to know that. Now the Patello-Femoral joint, lots of pain, people start getting pain in the anterior knee pain. When you have a full extension, then it is the lower pole of the patella which gets in contact in the circle. But as you flex, the more and more part of the patella will get in contact, and therefore the maximum loading of the patello-femoral compartment is around 30 to 40 degrees of flexion. And then these all stresses get from medial side to the lateral side, and that is how the the patient is started getting anterior knee pain, and that is what the patient complains of. That, sir, I get a lot of problem when I'm trying to get up from my squatting position, as in between I get lots of pain because the maximum force is being generated in the patello-femoral compartment from a extreme flexion to a mid flexion and then extension. Now, this is how the forces, the reactive forces are created between the patella and the femur. This is the pull of the forces by the quadriceps, and here is the forces by the patellar tendon. And this is the reactive force which is causing a pressure between the patella and the femur, and you will get a pain. Now, this is again the forces of the quadriceps, forces of the patellar tendon, and they try to push the patella onto the lateral side, and therefore it's a lateral subluxation of the patella, or the patello-femoral lateral patellar syndrome is well known. This is what we get. That neither two things can happen. Now, in a patello-femoral compartment, either you have a tight lateral structure or you have a lax medial structure. Most of the time, it is a tight structure on the lateral side, and the patella moves from its groove to the lateral side and causes a pressure here. As I told you, that most of the pressure is on the lateral side, and this is called as LPS, lateral patellar syndrome, and patient is getting pain. A very simple thing you have to do is just a small nick here and release the lateral structure by a scissor, and the patella comes back into position. The pressure here in the patello-femoral compartments is reduced, and thereby the pain will go. Or if there is too much of anterior knee pain because of the patello-femoral arthritis, of course you have the operation by which you can raise the tibial tuberosity, like McQuaid operation, and thereby reducing the pressure anteriorly between the patella and the femoral condyle, and the pain distinct. Now, this is what shows that how much is the stress on between the patello-femoral compartment with the flexion of the knee from 0 degrees to 90 degrees. So this shows that this is a weight bearing. So when you have a 90 degrees flexion, then during weight bearing, the stress is so much. And if non-weight bearing, the stress is much less. And if there is a 0 degree, that is, if the knee is extension, then in a non-weight bearing, there is a stress here, but not much stress during the weight bearing. So this gives an idea about this thing. So this is a brief about the time, because we have the Zoom and we can only talk about 45 minutes. And this is about the little bit about the surgical anatomy of the knee joint, and little bit about the biomechanics, which is not my field, but we did this. Thank you, John.
Thank you, sir. I request Arvind to continue with the moderation for the discussions and the questions.
Great lecture, sir. Very detailed elaboration of all the structure around the knee along with the biomechanics. So we have some question here. First question from Amit. When doing ACL reconstruction using single bundle anteromedial is reconstructed, how does the absence of posterolateral bundle amount for the full strength of this ACL reconstruction?
Well,
and,
anybody, I'm not in a orthoscopist, and I don't do any ACL reconstructions. My ACL reconstructions are done by my orthoscopist. So anybody who is doing an ACL reconstruction may be better to reply this question. Arvind, you are doing a lot of ACL reconstruction orthoscopically?
Yes. Arvind,
try to answer this time.
We are doing some cases, sir. Definitely. So when we are doing single bundle ACL reconstruction, it's not the anteromedial ACL reconstruction. We just check the center of the anteromedial and the posterolateral bundle, and where at that place we reconstruct the ACL footprint taken as, and we reconstruct the ACL. So depending upon the diameter of the reconstructed graft, sometime it may be 10, sometime it may be 11 or 12. And if this much of diameter is there, so that reconstructed ACL is taken as complete footprint, and a study has shown that in the long term, it's become anteromedial and the posterolateral. Though there is concept of the two-bundle reconstruction also, but nowadays lot of study has shown that there is no any added advantage of two-bundle reconstruction or double-bundle reconstruction over the single-bundle reconstruction. If graft diameter is less, so minimum at least more than 8 mm diameter of ACL should be chosen for the reconstruction. Anything less than that, a study has shown that the chances of re-tear is very high, almost more than 30% of.
Arvind, I have a simple thing that I want, since you are doing a lot of ACL reconstruction. After doing a good ACL reconstruction, in how many percentage of cases professional athletes and players can get back to their normal efficiency? Is it, I have known a few examples where people have got ACL reconstruction done and they have gone back to good professional games.
A very good question and very debatable question also at the same time, sir. So knee injury, from very beginning, John sir used to say the isolated ACL tear is very rare. It's almost always associated with some kind of injury to the meniscus, some capsular injury, and also some bone bruise and cartilaginous injury at the same time. So depending upon how much associated injury is there, if it is isolated ACL and some component of meniscal injury is there, most of the time player again back to the field with almost 90 or 95% of activity as much as before injury. But at the same time, if it is associated with other injury like cartilaginous injury or capsular and any other structural injury is there, so chances of recovery is not so good in such type of cases.
Yeah,
so
but
basically
that's the only chance that they can go back to sports. So if it's an unstable knee in a sportsman, I think you have to try to make it stable as far as
much as possible.
That they can go back.
It is, John, it is the, what my, lot of my arthroscopist friends are doing the ACL very frequently. Arvind, you are doing a lot of these things. One thing which very commonly I have found them, that they have a problem with the terminal degrees of extension. They have is it something wrong with their technique or something that they lack the physiotherapy, or because most of the patient come, they say, sir, they're not getting the full extension, or is it that when you are trying to give the tension in this thing and tightening them with endo button or whatever, it may be something that.
So most common reason, sir, is when there is acute injury and there is swelling, tenderness, hyperesthesia. Many of patients comes with some type of hyperesthesia also. So these 3-4 conditions, in such type of cases, we should not do ACL reconstruction immediately.
Yes.
Second most common reason is the placement of tibial tunnel too much anterior. In such cases, the graft get impinged in terminal extension with the notch.
Good.
And that prevents the full extension also. And sometimes, sir.
Yeah, so that means a little deviation from the standard technique that this can lead to this thing. That's what you're trying to say.
Yeah, definitely.
That's right, because of the impingement at the time of the full extension. That's right.
And also the physiotherapy plays an important role. I think in the initial period, if you allow them to develop a flexion deformity or a lag, then it becomes very difficult to get it corrected.
Yes.
That has to start right in the beginning.
Our arthroscopists have a rehabilitation plan, which they give it to the patient before the surgery is done, that this is what we expect you to do it. Then we have the physiotherapists who have been told that you have to achieve this thing. In spite of this thing, I think the patient cooperation is also very important in achieving a good results.
Yeah. You are very right, sir. Every patient is different, particularly ligament reconstruction cases.
Yeah.
So physiotherapy has to be very smart to identify which one we should apply for, which one we should not apply the force.
Arvind, since it is you are doing a lot of this thing, how often now you have started repairing the meniscus tear, or you are still doing the balancing? Of course, now nobody is doing a complete meniscectomy, because I know that what it means, and but people, my arthroscopy have started repairing this thing.
Yes, sir, you are right, sir. So definitely meniscus having very important role, particularly it convert the compressive forces to the hook stresses. And lot of literature has says it increases the contact area, so decreases the peak pressure over the cartilage. And meniscectomy has definite role that you have shown in your slide also. So in fresh cases, almost up to 2-3 months, we are doing the meniscus repair. But one thing has to be very clear in mind, that your suture, that what we are applying, that should be very accurate. And this suture should have finishes the gap between the meniscal surface that is torn. That is very important. So what we are doing in our mostly cases, we are using the circumferential stitches. That is very strong stitches. Along with that, it's very cheap also. Only thing we have to buy an instrument, that is a mini scorpion or a meniscus scorpion, first pass mini type of thing. That is very reusable, and we have to take any fiber wire simple. But in some places like posterior horn of medial meniscus, sometimes it's not very easy to apply that instrument. So all inside technique is there. That is also very good. Only thing is that we have to always check before doing repair. The margin of the tear is very much fresh and it's bleeding. And after repair, it should opposes to each other also at the same time. There should not be any gap at all, because your synovial fluid will not allow the healing of this meniscus if there is any gap or any instability after the repair.
The results.
So there are some more questions in the chat group. I think let's take the DNB questions first, and then we'll carry on. Yeah.
So next question is, while doing high tibial osteotomy, open wedge, what happens if posterior tibial slope increases? And how to definitely check if posterior slope is not altered intraoperatively?
You mean to say the doing a high tibial osteotomy? What is the advantage of doing a high tibial osteotomy? This is what he's trying to ask.
How do you assess the posterior slope, and how do you make sure that it is not increased or decreased?
Open wedge when you are doing.
I most of the time I have been doing a McQuaid type of high tibial osteotomy, okay, which is a dome osteotomy, which I do most of the time because I find it is gives me a better result because of the anterior translation that I can do it in tibia, and I can bring down the pressure in the Patello-Femoral compartment, and I can get the correction of the varus which is already there. Now, doing the open wedge osteotomy, one can, like the Coventry has decided, the amount of the wedge you decide and take and fix it with a plate, or some people are fixing it, putting it into the plaster at one time. Now there are different types of the plates people are using it. And again, I must say that the high tibial osteotomy is again coming into vogue. And many people are talking about doing a high tibial osteotomy in the early cases of an osteoarthritis. So that is what my say is. John, anything you to say?
Yes, so when you're doing an opening wedge osteotomy, one of the most important part to avoid problems with the slope is to make sure that the posterior medial cortex is cut.
Yeah.
If that is not divided adequately, when you try to distract, you're going to get a sort of more of an opening in the front and less at the back, and then the slope's going to increase. So I think that's one of the most important things. And then you need to monitor it when you're doing your correction. So there are different ways of doing it. You could put a guide wire parallel to the tibial slope and check that on your C-arm when you're doing it. You can, one of the things with the instruments that you have, you can direct your distraction posteriorly or anteriorly depending on how much you want to correct anteriorly and posteriorly. So those are the things you need to check.
I would just like my...
and you have to release the medial collateral adequately, otherwise it tends to stop the distraction.
Arvind, am I right in my statement to say that the more and more people are now inclined to do a high tibial osteotomy in early cases of osteoarthritis?
Absolutely. So I think we have been doing it now for many years.
But why I asked you this question, that at my place, the people are not very happy with doing a high tibial osteotomy. They say the best thing is to, sir, go ahead and do a total knee replacement, which gives in a one-time surgery and you get an excellent result with that, which I'm not, I agree to that because it's too early to fiddle with your own joint, where the high tibial osteotomy gives you fairly good results. Fairly good results.
So I think, yeah, we in fact, we are about to publish our 5-year results.
Okay.
We've been doing it regularly. I think first the surgeon has to be convinced it works. Of course, you have to select your patients fully. If you have tricompartmental arthritis or it's a rheumatoid case, then you're going to have a bad result. If you have too much instability, some amount of instability, you can compensate with your osteotomy by changing the slope. But if there's too much either ACL or PCL sort of deficiency, then it's not going to work. So I think you need to select your cases carefully.
John,
and in the young patient, you don't want to do a TKR at a very young age.
Exactly. John, which osteotomy, high tibial osteotomy, which type of osteotomy you prefer to do it?
So we do mostly the medial opening wedge using the Tomofix.
Oh, Tomofix, okay, right.
But we also do the Ilizarov one with the, not the Mackay dome, but the opposite. So it's a smiling dome osteotomy so that the cora is nearer the joint. As
what the drawer Palais has
that
recommended.
So,
John, I have a small query myself. These days, a lot of people, including myself, we are doing a lot of orthobiologics and doing PRP injections in these patients. We have done about, I think, 60, 70 patients. Do you have any experience with the PRP injection?
Very little, sir. And recently, interestingly, so there's been a big meta-analysis done by Mohit Bhandari. And they are able to come to any definite evidence of benefit with orthobiologics. Okay, with all these platelet concentrates, etc. There's no, I mean, yes, there's a lot of reports of improvement, but overall, there's no sort of study, randomized control study, which has been able to show that there is a definite difference between other modes of treatment and adding PRP or whatever else to it, biologics. But I don't know, it may change.
I perfectly endorse your views, John, because I also know about that Mohit Bhandari's study, that even our own 60 to 70 patients that where we have done the PRP, they have a, we cannot tell, and their results are not very encouraging, and I don't think, and sometimes they're recommending that you give this injection along with the steroids. Then the very purpose of giving PRP and creating a so-called has no meaning if you give it with the steroids.
So I think if they have any alignment problems, you need to correct that, and then you may add it. Whether it really makes a difference or not is hard to tell. But honestly, if there's any malalignment, then there's no point giving injections of any
PRP
and expecting it to work.
It only works in a very early stage. Only works in a very early.
And then if we treat them just medically with anti-inflammatory and exercises, a lot of them.
In fact, I started doing this PRP once I attended the workshop organized by Dr. Padriwala at Kokilaben Hospital when they got some people from Korea and those things, and they were talking very high about
Yeah.
PRP injection. But when we started doing it, our results have probably not been that this
I don't
thing.
think, so that's what so there's always this issue of hype and company sponsored studies, etc. So be very careful about vetting these
marketing driven situations.
And I can't comment about an individual study, but
Yeah, but yes, I fully agree. Similarly, you know that Australian group, which are doing that vascularized fraction from the fat, and that is the Australian group. And one of my junior colleague is doing a lot of cases onto this thing. But I myself was never convinced with that, and I still feel that achieving a biomechanical, making the joint more biomechanically sound will take away lots of pain in these patients. And therefore, I think the best alternative before you go for TKR is to get a proper high tibial osteotomy. That is what my experience.
Bearing in mind the age and the amount of arthritis.
The selection of the patient. Selection of the patient is extremely important. Yes, absolutely right.
So next question is, sir, proprioception is the function of ACL or PCL or both?
Mostly it is by the ACL. They have not talked about much about the proprioception by the PCL, and mainly it is the ACL they say plays a very important role.
Yeah. So
what happens when you replace the ACL? Does that give you proprioception or not?
So it's study has shown that the tibial footprint of the natural ACL is having proprioception.
Okay.
And reconstructed ACL proprioception is not much as the natural ACL.
Natural, obviously.
Natural, yeah. The natural ACL has got a much more proprioception than the our artificially created this thing. True, that is true for everything. Wherever, for example, you get your TKR done, that feeling and the natural joint feelings, there's a lot of difference. It will always be there. Yes, that is absolutely.
So next question is how to quantify the varus thrust gate.
How to quantify the varus gate?
Varus thrust gate, yeah.
Varus stress gate. I do not know what he means by how to quantify. I do not know what is what he means by this thing. Is there any method to quantify, Arvind?
At some literature, the grading of varus thrust gate has been written. The grade 1, grade 2, and grade 3. The grade 1 is simple. It's the dynamic bowing on the lateral side of the knee joint.
Okay.
The grade 2 is when this bowing is associated with some type of external rotation. Okay. And the grade 3 is external rotation along with the hyperextension of the knee joint.
Okay, that is how they are
quantifying
the whether. In fact, it is whether it is a mild, moderate, or severe.
Mild, moderate, or severe.
That's what exactly is. That's okay. Yeah, good.
So it also, in a way, shows the amount the ligament and capsular structures have got stretched over time.
Yeah, because you see, once you are walking with the water,
so you're going to continuously
for a longer time. Obviously, the structures onto the lateral side and on the posterior side, they all get stretched because your joint is working at a disadvantaged position biomechanically, and therefore you will get all these problems. Yeah.
And there's now enough studies which have looked at natural history with varus and especially varus with dynamic thrust, and they show that these knees always progress in terms of the osteoarthritis. More the varus, more the dynamic thrust, the more the OA progresses.
Yeah.
Next question is, does fibular osteotomy really work for early osteoarthritis of knee?
A lot of people, this has come from the Chinese people, and many people are doing this fibular osteotomy, and they're trying to say we are trying to make it a biomechanically a better joint than this thing. I myself have not done any of these cases of doing a fibular osteotomy. But yes, in some literature, and especially from Chinese, people are doing. I do not know whether Arvind and John has done any fibular osteotomy to achieve the biomechanics into the normalcy. Have you done, Arvind, any?
John sir has done revision of that
So
fibular.
we've done osteotomies in patients who come to us with previously done PFOs. So I think we've done 3 now so far.
Okay.
And within a year, 1
In
year.
a short while. And interestingly, one of them had bilateral PFOs.
Yeah.
And okay on one side, but the other side had no relief.
Yeah.
So it's hard to understand why some of. So there is a fact that some of them do get relief. There's no. I don't think that is. Predictability again is very poor.
Another problem is they say sometimes you get patients who had some injury to the patella during their younger age or some other problem, that instead of getting the medial and lateral compartment involvement, they get the Patello-Femoral compartment involvement.
Yeah, so that's
it is a Patello-Femoral then arthritis which is causing them pain. What is your approach to such patient where it is the medial and the lateral compartments are fairly good, but the Patello-Femoral compartment is giving them lots of pain? Any say on that?
If a patient is younger, so particularly for the Patello-Femoral pain, we have done some osteotomy in form of Fulkerson osteotomy, anteromedialization of the patella. But in that case, the causes should be very clear that the tibial tuberosity is externally placed. At the same time, there is cartilage loss of the patella. The selection of cases in such type of the patient is very important. We have done this Fulkerson osteotomy, and again, the patient is having relief. But all these patients are very younger patients, not very old patient, less than 40 or something like that.
They are mostly in the age group of between 40 and 50 because they had some patellar fracture or some problem. And you see, there are 2 things that we, at one time when we were doing a thesis on this thing, 2 things that we found. One was that lateral patellar syndrome, where you could do a lateral release. The other thing was what the literature said was doing a sort of a tibial tuberosity and trying to lift it up and thereby taking away the pressure from the patello-femoral compartment, what they used to call as an immaculate operation, whose name the dome osteotomy goes. I have not done many cases, but I did about 2-3 cases. But my observation was that tibial tuberosity raise operation, the quadriceps will become weak, and they always had some type of an extensor lag, and they were not. They said pain has gone, but they say the knee is now not that stable. Then once I got to know about that from patient observation, I stopped doing that operation. I said forget about it, continue it for some more time, and when the time comes, go ahead for the total knee.
So for any of these, you would first treat them conservatively, physiotherapy exercises, strengthen the tensor fascia femoris, etc., and the VMM, and only then would you think of doing surgery for a pure femoral arthritis. Sometimes it's combined with lateral subluxation, and then it's a different situation where you might go on to surgery earlier. Then you have to assess all the alignment,
in totality, in the totality of the whole case. That's how it takes.
The MPFL, the lateral structures, the trochlear notch, everything has to be assessed, and then we try to decide on what procedure would help in that patient.
Next question by Sachin. Kindly elaborate the mechanism of screw home mechanism.
The screw home mechanism basically is causing, by the nature it has provided, to bring in the stability at the joint whenever you are standing. So you see, when there is from a flexion position, you are going into an extension, then about 10 to 15 degrees short of extension, it is the external rotation of the tibia that takes place, and the internal rotation of the femur that takes place. And in that position, the whole joints get absolutely into a stable position. This is what is called as the screw home, or what is called the locking of the joint. And then the patient, while is standing and a stance phase in the erect position, knee is absolutely stable, and you will not have a sudden fall or something. For unlocking this thing, of course, is when you're trying to flex the knee joint, then the popliteus comes into the action. The tibia goes into some rotation medially. The joint gets unlocked, and then the hamstrings come into the action, both lateral and medial, and you can get an flexion that is called unlocking of the joint.
Yeah, I think it's important in that when you're standing, you don't want your muscles to be working overtime.
Yeah.
And the idea is if you lock the knee, then your stability increases and your muscle don't have to work to keep you standing straight.
By screw home mechanism, the knee is in a stable position, and the muscles don't have, what John is saying is absolutely right. Muscles don't have to contract both posteriorly and anteriorly to keep the knee in that position, stable position. That is the advantage of having a screw home.
Yeah,
and that's why if you have a flexion deformity, even a slight flexion deformity causes problems both with walking and standing for a long time.
Yes, yes.
Yeah, nicely elaborated, sir. So as you have already discussed that the center of rotation of the knee joint is more toward the medial side, because the medial condyle is bigger and the lateral condyle is smaller.
Yeah.
And as we extend the knee, so in the last 10 degree of extension, the rolling of the lateral condyle gets finished, but only the medial condyle which rolls over the tibia, because tibia get extended.
Yes.
And there is external rotation of the tibia. So in that position, the knee get maximum stable. So that is the screw home mechanism. So because of that mechanism only, the knee is fully stable.
This is quite a sometimes a short notes for the DNB students in the examination also. So they should be able to answer it by making a diagram and showing how the rolling and sliding takes place and how the rotation takes place. It's in quite a short note in the DNB examination. Yeah.
Any more questions, Arvind? Otherwise, it's already 7 minutes.
Question has been finished.
Okay, good.
All questions discussed.
So there's someone asking about cruciate retaining TKR over TKR with cam and posterior. You mean posterior stabilizing?
Yeah.
This is something you can argue till the cows come home. I think depending on your preference, you would decide. So I think you need to look at how much deformity there is, how much degenerative changes, how tight the knee is. And if it's a relatively mild case, then you can do a posterior cruciate retaining knee. Otherwise, it becomes difficult and you may have more problems on the other side. But it's really more of a personal choice than anything else. The argument is that if you retain the posterior cruciate ligament, there may be some improved proprioception, but clinically, really all the studies haven't shown any significant difference between the two. Arvind, you want to add something to that?
Perfect, sir.
Similarly, everyone has his own choice these days. Now, when we were taught about the total knee, that the patellar resurfacing must be done. Now, most of the knee joint surgeon authors are not doing any patellar resurfacing. They are leaving it as such. They say it is not required. I think those who do a lot of cases. And another thing which to John and Arvind, whether it is a fashion or it is a need of the day, we are in Indore, we are getting a full page advertisements in the Daily Mail that we have now got a robotic and we are doing TKR with robotic. And at one time there was a fashion that we were doing a computer navigation. Now nobody is talking about computer navigation and everybody, they say robotic. I don't think, I think this is my personal feeling, it is a more of a marketing gimmick and
So I
those who do
think-
lot of total knee. Because I tell you, I talked to Ranawat, he said all bullshit. I rely on my own eye and I see what cut I'm making. I give much better result. I never use computer navigation, etc. I do not know. Even in Patna, there is a robotic.
Yeah, I know. But so the thing is, it's very difficult to prove or disprove one way or the other. Because to show that there is a significant difference, you have to do a long study over a period of time with a large number of cases. Only then we can really show that there is a difference. Now, the studies with navigation and with robotics show some minor differences in terms of accuracy of alignment of the knee. But in terms of clinical results, we still don't have any studies to show that it's superior to doing a conventional knee. So it depends on the surgeon a lot, and more than anything else, that is probably the most important factor.
Thank you.
Okay,
Thank you, John, so much. Thank you, Arvind. I
Okay,
enjoyed.
So thank you very much, sir, for giving your precious time.
Yeah, thank you.
And this discussion must help all the DNB students. Thank you, sir.
Thank you.